Good Thursday morning. It is September 9th. We are live inside the Dolph Simons Jr. Family Broadcast Studio today. Welcome into the Morning Medical Update. Today, we are talking with Dr. Brian Holmes, a self-proclaimed good old family doctor from Abilene, Kansas, whose patient made national news recently when the closest transfer space available for that patient was 570 miles away. He'll have more on that story and the efforts to get folks in his neck of the woods to mask up and get vaccinated. But first, Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, joins us with our COVID count. Good morning. How are you?
Hi, I'm good. Hi. I think we're doing pretty good here at the health system, too. So first of all, just start off, Hays has 14, 9 active patients, and 5 in that recovery period, so a total of 14. We have a total of 100 patients, 50 active infections, which is down a little bit, 16 of those in the ICU, and 9 on the ventilators. And as of yesterday, only 2 of those in the ICU were fully vaccinated. So again, the majority of those patients in the ICU are unvaccinated. We also have 50 additional patients that have met that recovery criteria, and so that's why we have 100 total, but again, 50 active patients. We did have 2 inpatient deaths, though, on September 8th, so yesterday we had 2 inpatient deaths. And just a few numbers that our Amanda Cackler put together with our Infection Prevention and Control Director and leader put together. Basically, last Labor Day for our census, we had 21 active infections compared to this Labor Day. I think we had in that high 50s or 60s active infections. And as of September 9th, we've had 18 deaths in September, whereas last year we had 17 deaths in all of September. So we aren't even halfway through September yet. And as far as August of this year, August of 2021, we had 37 deaths, whereas last year, August 2020, we had 18 deaths. So you can see our numbers are drastically changed from the same time point last year.
A question we get, though, when you talk about 2 deaths that we had, people ask here on our show if they were vaccinated. Do we know if the 2 deaths that you mentioned, if those folks were vaccinated?
Yeah, I don't have that information. That was not given to me.
All right. Dr. Hawkinson, thank you.
But I would say we do try to give vaccination status for our patients periodically, once or twice a week.
Yeah, it's just a concern for people. I hate to hear when a death happens, they want to know, did that person, was it a breakthrough case? Were they vaccinated or not? So I had to ask.
And again, we have had deaths in those vaccinated patients. Again, a majority of the patients that are vaccinated in our hospital, we saw this last week, a majority of them are that group that requires additional or third dosing, so those immunosuppressed populations.
All right, makes sense. All right, Doc Hawk, thanks. Hang tight there for a second. Let's check and see if we have any reporter questions on the line today. Go ahead.
Sure. Good morning. Cody Holyoke with KMBC 9 News. Piggybacking off of what Dr. Hawkins just said, I'm curious, Doc Hawk, when we look at the comparison, what should people glean from that?
Yeah, I mean, I think it's gleaning the same message we have been talking about, going back to the vaccination status, although I don't have the vaccination status of the 2 patients that died yesterday. But we have to understand what we saw from our vaccination numbers yesterday is that the majority of the patients that end up here in the hospital are unvaccinated. It is that small percentage that are vaccinated. Again, we tend to have a little bit higher vaccinated population in the hospital because of our selection bias. We are getting transfers from outside. We do have a large immunosuppressed population as well. So I think that is really the message that we need to continue to give, and that is the true message and has been going on since vaccination has become available. And again, that is getting vaccination now, just as before, continues to reduce your risk of coming here to the hospital, having severe disease, going to the ICU, and of course dying.
Cody, do you have a follow-up question?
I do, thank you. So I believe it was the American Academy of Pediatrics came out and said that more than a quarter of the weekly COVID-19 cases involve kids now. I'm just curious your reaction to that. Is that something that you and even Dr. Holmes might be seeing in Kansas? And what should people be doing about that?
Yeah, I know that our colleagues at Children's Mercy do publish their daily data of inpatients. Again, these are cases that you have described, not necessarily hospitalizations. However, we do know that around the country, and even here from what we've seen from Children's Mercy, from what they've reported, is that right now during this surge, they have seen more children coming and staying in the hospital than they did at any other time in the pandemic. But there is good data to suggest also that those areas, those geographic areas that have high vaccination rates, do lend protection to those children as well by helping decrease the spread. So I think it goes back to vaccination. I know I sound like a broken record, but unfortunately or fortunately, that is what we have, and we know that they work. Unfortunately, for children below 12, they are unable to get vaccination. So everybody who is 12 and over should be getting vaccinated. If you know people who are unvaccinated, please encourage that, because that will help keep our children's cases down as well. People are concerned about their children being isolated and at home and not being in school. Getting those children vaccinated is going to help them avoid those sort of situations moving forward.
Dr. Holmes, what can you add to that?
Kind of hard to follow Doc Hawk, but first I want to say thank you for having me on the program, and it's always a pleasure to be able to be on here and talk to everybody. But we got to get people vaccinated. Unfortunately, the timing of it didn't work for school when it started. Not enough folks got vaccinated. We have about 52% of 12 and older in our county that are vaccinated, which is higher than what I thought when I got the statistics. But we just got to keep pushing the message to protect our society.
Other questions on the line? All right, so we're going to get to our community questions here in just a moment, but I want to get back to Dr. Holmes. He's the medical director of ER and the lab at Memorial Health Systems in Abilene. So welcome in again. Good to see you. Thank you for being here. I just want to let you just start by telling us a little bit about what's going on there in your town, and what can you tell us about what's going on in Western Kansas?
Well, technically, we're not Western Kansas. We have to define that. Most people west of Lawrence or Topeka define the rest of the state as Western Kansas, but we're considered North Central, just a point of definition. But, we have a lot of folks out here that unfortunately don't trust medicine or don't trust the government. And it's created some chaos for us and division within our communities. But, we keep beating the drum, try to get the message out that the vaccines are safe. They're fully FDA approved now for Pfizer. And by far, you're more likely to have issues with getting COVID and complications with that than you are with getting the vaccine.
So are you having to, what are those conversations like with your patients? Are you having to have some tough conversations with them? Are they asking questions about the vaccine? Are you having to push and really do a lot of convincing? Are you letting people kind of come to the table when they're ready? What are those conversations like?
Well, I think most of my patients understand where my stance is on vaccination, but every office visit that I have, I take the opportunity to look and see, have they had the vaccine? And if they have, I thank them for doing their part to help our community and to get out of this pandemic. And then if they haven't, then I try to have just an open, honest conversation with them and ask them, do you have any questions about the vaccines? Do you have any hesitancies? What can I do to help you make a decision on this or to potentially get vaccinated? And, I push a little bit here and there, but you can tell in their faces sometimes as soon as you mention it, they'll look down, they'll look away from you. They might get a little smirk on their face or just kind of fold their arms, and there's no way you're going to convince them to do it. But, I also moonlight in another facility in the emergency room, and so I get to see some of the tragic stories that unfold in true life right in front of you of these people that are unvaccinated that come in. They may not look that ill, but then you look at their oxygen saturation levels and they're in the 50s and 60s, and they end up being on high flow oxygen and sometimes even need to be intubated. And to see these healthy, hardworking, normal Americans that are suffering needlessly is just, it's overwhelming sometimes emotionally to us.
Right. It makes you wonder if those people were able to really see what you see every day, if it might sway their thoughts on the vaccine. I want to talk about transfers because that's been a big issue across the board at really almost all hospitals, certainly here at ours, and I know with yours as well. In the last month, you've had 4 out-of-state transfers, as I understand. 1 patient flown to Oshkosh, Wisconsin, for an ICU bed. Took you hours to try to find this room. Could you just tell us what that was like for you as a physician? Tell us that story so we can understand what was happening.
Well, Dr. Brown was the actual physician that did that transfer of my patient for me, but she couldn't be here today. But in talking with her, it took 5 to 6 hours to find a bed for this guy who had been in our hospital for already a week on high-flow oxygen with vapotherm. And we saw that person was declining and kind of knew that it was inevitable they were going to be on the ventilator, unfortunately. And that did come to fruition, and the family was adamant they wanted everything done they possibly could for their loved one, which we understand. We tried using the mission control system that's set up through KDHE. The staff then, including Dr. Brown, and luckily she had a med student at the time who was very diligent in making phone calls, and they eventually just kept calling, and Dr. Brown had been at school in Appleton, Wisconsin, and so she had some contact up there still, and luckily one of the charge nurses they talked to at another facility that was full referred them on to another one. They actually had an ICU bed available, and they were welcome. They took the patient and had to go by fixed wing. It was an ordeal because you got to think about how you're going to keep this patient sedated for hours on an airplane, and that created a little bit of a challenge for us as far as medicines and getting that ready. But it's been hard. We've especially COVID positive patients, trying to get them to an ICU bed is next to impossible at this time.
And I was talking to the gal here who runs our transfer center and makes those phone calls that you were talking about. And she said it's like heartbreak on both ends of the phone, the desperation from the physicians calling to try to find a bed for their patient, and then the heartbreak when the other end of the line has to say, we don't have that. What are your concerns right now when you watch these kind of stories unfold? What concerns you most?
Well, we're seeing, or going to see more, I think, rationing of care in the U.S. And we've been spoiled to this point. We really haven't had to deal with that. But these, COVID and the pandemic, these patients that come in, they don't just stay 2 or 3 days. They're here for a week or longer. And you've seen people in the ICU even for over a month. And, normally the ICU has people come and go pretty quickly. And when you lose that cushion and you don't have the volume to move people in and out for other normal time critical diagnoses like trauma and heart attacks, strokes, et cetera, it puts a severe strain on our system. And I think Idaho went to some sort of emergency order issue now with treating patients. And we don't want to get to that point. But at one time, in our facility, we're a 26-bed critical access. We have 2 BiPAPs and 3 vapotherm machines. And at one time, we had 2 vapotherms and 1 BiPAP being used by COVID patients. And it would only take 2 or 3 more patients to come in and overwhelm us with COVID that need oxygen at a high flow, that all of a sudden you're picking and choosing who gets to be on these machines and who doesn't. We don't want to be in that position. We want to be able to treat everybody the same and give them the best care we possibly can. And so, that's kind of my biggest fear when I think about trying to take care of our community.
Well, Dr. Holmes, a question often, sadly, we get from our viewers is just that very humble question of, if I get sick, is there a bed for me? Someone who doesn't have COVID, how do you push that message out there that we have, a big question was, do we have enough beds? That's always the question. And there are limited beds. We do not have infinite beds across the country and in our hospitals. So how do you send that message that we will run out of beds?
Well, I preach to my folks, whoever will listen, don't get in an accident. Be careful. Don't do anything silly. Don't put yourself at risk with your activities or driving and even your own job. We have a lot of farmers around here and accidents happen. It's not a bed crisis as far as the number of beds. There's lots of beds. And I know you guys have talked about that before. It's staffing. We don't have as many nurses in this profession now this time of year compared to last year. People are burned out. They've left. They can't do it anymore. But, there may not be a bed for you. And that's hard to even think about saying, but it's true. And we just got to be as careful as we can. We got to get people vaccinated because they're the people that end up getting sicker, having long-term effects with long COVID, and they're the ones that are dying.
Yeah, you make a good point. It's not just the beds; it's also having a healthcare provider at that bedside to get you well again. I want to talk about schools. We talked about it just briefly there just for a moment, but school back in session, waiting for vaccines to be available for those under 12. Just what are your concerns there, and making sure that it's tough getting adults vaccinated. Now you're going to have the added issue of having to get kids vaccinated. Talk us through that. What you're seeing, what your concerns are, and thoughts.
Well, there's a lot of fear still out there for children, and all the conspiracy theories about infertility and what are the long-term effects. I think Dr. Poland has been on a couple of times, and I've tried to watch all these episodes as I can over the last year. But he made some good points about this is the perfect storm. We don't have kids that are vaccinated or even eligible to be vaccinated, and we're putting them into facilities with poor ventilation. And they're there for a long time period, and they're not wearing masks. And it's just a matter of time before this backfires on us. And I think we need to be stronger at our mitigation that we're doing, and do everything we can to ensure that kids can stay in school and not be hampered with having to be homesick.
I want to go back to also something you talked about, this social issue, the division that you're seeing, because it's not just where you are, it's where we are, it's all across the country. You're a hometown doctor. How hard is it, though, to see that division and reaction against well-known facts in science? How are you managing that and feeling like it's a big uphill battle, if you will?
It is. It's very disheartening to work your whole career and at basically trying to keep people healthy and public safety issues, and to then have that discredited. It's soured a lot of people in our profession, and we aren't doing this for reasons. I mean, we're all pretty altruistic people. We want to do the right thing. We want people to be healthy and to live their best life they can. It doesn't make sense to fight a political fight on masks, and it's a tool that we use every day in healthcare, and it's not a political statement. It's been way too divisive in across the country, and we've got to get past that in order to move forward, I think.
Well, we're going to get to some community questions. Thank you for sharing with us what's going on there. But I want to jump in with some community questions today because we've already got one for you, Dr. Holmes. Adam says, does your hospital have an ethics committee for assisting physicians and healthcare personnel in those decisions that they're having to make?
I know we've talked about that before. We have a loose ethics committee as far as we can pull one together, but I don't, in the 20 plus years I've been here, I don't know that we've ever had to bring that out and actually do it.
Any other, what are the decision-making processes there? I know that they vary from hospital to hospital, but just making these type of decisions and transfers and things like that, how does that work? And just walk us through that process a little bit.
Well, we have finite resources that we can use, whether it's staff, equipment, bed space, and you may get pulled into a situation where you've got 10 people that need 5 pieces of equipment, and how are you going to choose who gets what? And do you base that on age? Do you base it on comorbidities? Do you base it on it's your friend or it's your friend's family member? There's a lot of things that go into it, and it puts a tremendous amount of pressure on the provider, or also the staff. And so we just don't want to get to that point if we don't have to.
On that note, Dr. Hopkins, question for you, and then Dr. Holmes, let me know as well. Again, along the same topic, Julie says, do we have enough ECMO machines for COVID, heart patients, other type of patients that might need it? Doc Hock?
We do have several ECMO machines here. We do have some of our stock or 1 or 2 machines that we hold back for those heart transplant patients. Again, once you get to ECMO, it is really the last resort to trying to keep you alive. So we don't have a lot of requests for those, and it is very strict criteria to meet those. But certainly the ECMO machines are less prevalent. There's not just as big a supply as with the ventilators, but also it takes a lot more specialized nursing. It takes a surgeon to place those big lines to exchange the blood. But overall, once you get to that point of needing ECMO, it is the last kind of resort to saving your life.
Dr. Holmes, ECMO machines in your area, enough for everyone?
No, the ECMO machines that we would use are at KU. But we have heard that there's been patients who have been referred to KU and unfortunately for ECMO and have been declined because they just don't have the capability to give it to everybody.
Do you think that's a problem, though, that a lot of people think that every hospital has the same type of abilities to take care of them? Is that a concern with some of the people there? Do you think, Dr. Holmes, that people think they could, anything happens, that they've got a hospital right there in their community that can handle any and everything?
Well, they know we have limitations based on just the size of the hospital that we have and how many docs and different specialties that we don't have here. I mean, we have family medicine, we have a general surgeon, we have CRNAs, but that's it. We don't have all the different other specialties that can help these people. And so we do the best job that we can. We have a great staff here. We've done an outstanding job, I think, of taking care of our community as best we can throughout this pandemic. And certainly we want them to come to us if they have a need, but there's only so much we can do sometimes. And, a lot of these trauma patients and that we have to ship out, and that's becoming difficult because there aren't beds sometimes. And if you have a trauma patient that's COVID positive and needs an ICU bed, good luck.
And you are doing a fantastic job. Thank you. And thank you for taking care of those patients. We know you guys are working hard and your staff is tired. You talked to Dr. Holmes about rationed health care. Jan has a question, and Dr. Hopkins, and I'll let you answer for us, but it says, is KU Health System close to implementing rationed health care as they're doing in northern Idaho? Just explain for people what rationed health care means. Dr. Holmes, I'll let you get started, and Dr. Hopkinson, add in, please.
Well, I think it means you're at the max. You're maxed out in your healthcare system. You can only do so much, and then they have to go to ration care, where you determine who can get certain elements of healthcare that they can provide and who can't. And we don't want people dying in the hallways or dying trying to get into the emergency room and dying at home because they can't get treatment. We want people to be able to get the proper care. But Idaho is at a critical point where they can't do that for everybody, and so they're having to make some hard decisions.
Doc Hawk, would we ever see that here? And how do you even make, and if we don't, but even if we did, how do you make those decisions? Who's sick enough? Who gets turned away?
I mean, certainly we had those concerns early on in the pandemic, more with those critical drugs and those ventilators. Those critical drugs I'm talking about are sedation drugs that keep you comfortable on the vent, pain meds, to keep you comfortable or paralyzed on the vent so that the vent can do its job and rest your lungs and keep your body comfortable. Right now, we haven't had to make those decisions on rationing care. If it is, it would be more on the basis of what do we have available to us? What are our resources? Do we have enough ventilators? Again, currently we do. Do we have enough of those critical drugs to keep you comfortable and safe while you're here in the hospital? And currently we do. But there are no thoughts or concerns right now about having to ration health care. Again, new studies just coming out. So far, all of the best evidence saying that getting vaccinated is going to reduce your risk by 70, 80, 90% of coming to the hospital and going to the ICU to even need those, to even have those considerations. But as of right now, we don't have significant discussions or a need to be able to ration health care for those patients.
Is rationing health care a rarity? I mean, is this a very rare event that would happen?
I would say it's a very rare event. We didn't really have to necessarily do that pre-pandemic, but certainly now, and again, more at the beginning of the pandemic with those critical medicines that we need or the ventilators or things of that nature, it has become more into the conversation.
Dr. Hopkinson, Christy wants to know, has the health system had to transfer people to other health systems? Has the health system had to make transfers
Not that I'm aware of. Again, we are more of a the large referral center, so we get the transfers. We tend not to have to transfer to people out to other places, say for an increased level of care. Once you're coming here to most medical, academic medical centers, larger health systems, they are really the referral place, so they are getting all the transfers in. So once we have a patient, it's rare circumstances, say maybe if they need to go to another place for family or other social reasons, we can try to transfer them. But as far as for critical care or care services, we are generally that referral place, so we are getting transfers in.
We don't want to turn anyone away.
Correct.
Okay, so quick question, Dr. Hawk, also, Kitty wants to know, should fans be wearing masks at Bill Snyder's Stadium for all football games this season? It's officially football weather and people are outside, but should they be masking, even the vaccinated people? What are your thoughts?
You want me or Dr. Holmes?
I'm going to let you go, then I'm going to ask Dr. Holmes.
Again, I think there's a lot of gray area here, and I think a lot of experts and public health people may have differing opinions. We heard differing opinions yesterday about if you are in those crowded stadiums. It was related to the Chiefs, but we heard Dr. Stites say he will wear it. Outdoors, we've always said, is much better. I think it just depends on what your risk tolerability is. Are you vaccinated? You definitely should be. But then if you're outdoors in that stadium, especially there's going to be probably winds and good air current, air movement, you should be safe. But again, I think it's taking those situations into context and understanding what they are. If you are going in the concourse or inside and going to the restroom or getting something to eat, it's probably a good idea to wear your mask.
Dr. Holmes, football's here, so is COVID. What should people do?
Well, you just got to protect yourself and protect your family and look at trying to protect your community. You don't know who you're going to be sitting next to or what their vaccination status is. How sick are they? Are they an asymptomatic case right now and they're got thousands of virus particles that they're expelling into the air on every down that the defense is out there for their home team and making a lot of noise. And so wind currents matter. You don't want to be downwind compared to all these people, but you just got to be careful. I think wearing a mask outside in the right situation is not a bad idea, especially if you're going to be in a large group and you just don't know what their status is.
Yeah, the K-Staters. They're hollering, they're screaming, they're excited, and they're close in there and they're having a good time, so like everywhere. So thank you for that. And then a question, Jessica wants to know, wondering why monoclonal antibodies are not readily available in Kansas City like they are in some southern states. Is that true, Dr. Hawkinson?
I think we actually have really good access to monoclonal antibodies here compared to what we're hearing from our national infectious disease colleagues around other places. We do have several centers that give them. We do have our center here. We have our infusion center that is able to give them. We also give them in our emergency department. We know that other places around the city do have access as well, either through their emergency department or calling their hospital in particular. So I think we actually have pretty good access to the monoclonal antibodies for those people that meet the criteria for getting them.
Dr. Holmes, Ruth Ellen wants to know, what percentage of your hospital staff is vaccinated?
I want to say it's somewhere in the 60 to 70% range. I can't give you an exact number. But, we have folks here resistant to it, just like anywhere else across the country, unfortunately.
And you said about 52% in the community, 12 and up, vaccinated?
12 and up is, 52% according to Johns Hopkins data.
And you said you were surprised by that number. You were thinking that was pretty high?
Yeah.
That's good.
I thought it was higher than I expected because we were not one of the higher vaccinated counties in the state, but we have seen an increase. We have about 73% of those over 65, which I thought would be higher actually. But, it's just all across the board what people are thinking and trying to get people to quit the politics of it and just go out and get the vaccine has been an uphill battle at times.
52 and growing, hopefully. Sandy wants to know, Dr. Hawkinson, is KU turning away anyone now? can smaller rural hospitals send patients to us right now? Can we take them in?
Yeah, I don't have the full answer to this. I'm just not a part of that transfer center or the executive group in that way. We know that during the past few weeks, we have had to turn people away. Certainly, we have seen today that our active COVID infections are going down. That's good. But you also have to remember we do have a lot of patients who are here for those non-pandemic reasons, the heart attacks, the strokes, the other surgeries that are needed for one reason or another, other infections other than COVID. So we do have a very high census. I'm not fully aware of what our total ability to accept transfers or need to turn them away is right
You don't
now.
have all the answers? Is this what you're telling me?
Very
all
few,
the answers?
very few.
We expect so much out of you every day. Okay, so this person has a question. I'm fully vaccinated with the Pfizer vaccine. I'm going to Florida next month. It will be too early to get the booster. Should I still try and get one? She has rheumatoid arthritis, so she's immunocompromised. So is it okay to get it a little early?
Yeah, I mean, if you are on immunosuppressive drugs, those ones that reduce your immune system because of that rheumatoid arthritis, I'm not aware of that the rheumatoid arthritis in itself is an immune compromising condition. But if you are on medicines for that and you meet that criteria for an immunosuppressed population, you definitely get your additional dosing or your booster. As far as if you are not immunosuppressed and just have rheumatoid arthritis, there will be guidance from the Biden administration, I think, coming out next week, detailing if certain groups are available or can get additional or booster dosing. We know that there is a disconnect and there is some debate between the CDC, FDA, and the Biden administration about that. We also know that the World Health Organization recently put out a statement wanting other countries, particularly the United States, to kind of put a pause on the booster dosing for those non-immunosuppressed populations. So it is really difficult to say right now. There is not a lot of information. Next week there will be more information, and if they do allow boosters, there may be caveats to that. There may be age restrictions, such as those over 60 or whatnot. But we are still waiting to find that out. In addition, we know that right now extra dosing is safe. We have data to suggest that, both in the immune suppressed populations and with other populations as well, saying that these mRNA vaccines are safe. And it's really difficult to police. So people, we know that a lot of people have walked into other places to get additional dosing. However, I would just say that right now it's not needed. You are still extremely well protected against coming to the hospital, going to the ICU, and dying if you are fully vaccinated. And that's even if it was 6 or 8 months ago. You still have very good protection from these vaccines. So kind of just sit tight. We will see what happens and what comes out from the administration probably next week.
Larry wants to know, a couple more questions. Larry wants to know, after you have monoclonal antibodies, have you had any patients still end up in the hospital?
We've had some patients come to the emergency department and for the hospital. Some were not due to COVID reasons, but what we found from all of our data, from as many doses as we've given now, which I think is over 500, is that our data is consistent with the trial data, in which we've had, about 3% have to come to the hospital. So a very low percentage. So it is protecting the vast, vast majority of those patients that are getting the monoclonal antibodies. And we are actually happy with that. I mean, reducing the risk of coming to the hospital by 97% is a pretty good thing.
Yeah. Okay, last questions from Isaac. Dr. Holmes, should an unvaccinated patient be put lower on the triage priority list or even turned away entirely? Seems obvious, but a lot of people have complained from an ethical standpoint. I hear this a lot too. What do you think about that?
Well, that's a great question, but a tough question. I mean, no one wants to do that to anybody, as far as if you're not vaccinated, to all of a sudden just kick you to the curb. We want to take care of everybody. It is frustrating to see these people come in and tie up resources that didn't necessarily have to happen because they chose not to get vaccinated. But it doesn't mean we're going to treat them any differently. We're still going to try to give them the best care that we can, because they're our community members, they're our friends, family, loved ones, and just because they didn't get vaccinated doesn't mean we don't care for them. So we're going to still treat them the same and do the best we can. But you hear of other doctors that refuse. I think there was a lady in a position in Florida that indicated she was no longer going to see unvaccinated people other than virtually. And part of that's to protect herself and to protect her staff and her other patients. And I get that, but I just don't know that we'll get to that point yet.
Dr. Hopkinson.
Yeah, no, I love that answer. I think that's completely correct. You notice that when I answered the question about rationing healthcare earlier on in the show, what we talked about was lack of resources such as ventilators or current important critical drugs or medicines. Not our opinions based on whether or not some person did something or did not do something. I think that's very important because I think as providers, every day we see people we may not agree with their actions that they've taken or what they've done, but that has in no way caused us to ration healthcare for that reason. So I would totally agree with Dr. Holmes. If there is any rationing going on right now, it's currently going to be based on the resources that are available, not on our opinions or editorials on some actions that may or may not have been taken by those patients.
I'm going to sneak in 2 quick questions. Dr. Hopkinson,
Yeah.
Does CoQ10 help prevent inflammation during COVID infection? Andy would like to know.
Nothing I'm aware of. I think you can take it. You can take any of those supplements in the recommended doses that's on the bottle from those over-the-counter supplements. But what we have found is that all of these supplements that have been looked at so far, vitamin C, vitamin D, anything of that nature, really does not seem to have any protective effect against getting infection or against progressing an infection. But again, if you are taking supplements and you want to take them, you're welcome to take them. I would just do it in those recommended doses.
Dr. Holmes, I have to ask you, we have people wanting to take things other than the vaccine to prevent COVID, to get rid of COVID. Do you have patients asking you for other avenues to treat COVID or prevent COVID where you are?
Yeah, I've actually been threatened in the clinic during office visits with, you're going to give me hydroxychloroquine or you're going to give me ivermectin if I come down with this virus. And I just have to simply tell them, look, if ivermectin and hydroxychloroquine worked or some of these other different things out there, I'd be the first one to give them to you.
Yep.
But until the data is there to prove that they work, I'm not going to potentially cause more harm. And, Merck came out with a statement here recently that makes ivermectin, saying, do not use this. It's not intended for COVID treatment.
Dr. Hopkinson,
Yeah.
he's threatened.
Yeah.
I mean, when you hear things like that from a fellow, physician, what does that do? I can't believe it.
It's unfortunate. We are really here just to help people, get them feeling better, get them back to a quality of life, get out of the hospital or stay out of the hospital. We take great pride in really using evidence-based medicine, and that is taking all of the data, looking at that, critiquing that, and understanding what is correct to use, what isn't correct to use. So I think that's important to know, and that we do spend a lot of time doing that and take a lot of pride in that and making our patients feel better. But right now, again, it's not our opinions that we shouldn't be using ivermectin. These are statements that are brought forth by the FDA, the IDSA, which is the Infectious Disease Society of America, the World Health Organization. All of these places recommend against using that, against using ivermectin and against using other drugs too. It's not just ivermectin. And then, of course, we know that the NIH says there is insufficient evidence to recommend for or against. However, if ivermectin is used, it should be in those clinical trials so that we can obtain the best data and do that data analysis and critiquing and really understand, does this work to prevent disease? Does it work to prevent disease progression? But right now, the best evidence that was obtained showing benefit, those large articles have been taken out of press, and they've been debunked as having significant problems and caveats with their data and their data analysis. So right now, we are not making this up. We are just going by the statements by the large bodies that really look at this in and out and look at all the details. And again, it's the FDA, it's the World Health Organization, the NIH, and IDSA as well.
I want to get to our final thoughts today. And Dr. Holmes, I want to start with you. And you said you were getting pushback from people in your area. You certainly were not kidding. Thank you, just first of all, not just for being on today, but just for helping to fight this pandemic where you are. I know you and your staff put your whole selves into this every single day. So thank you so much for caring for our communities and our people. We appreciate you so much. And just what are your final thoughts for us today? What do you want us to know?
Well, I think I got a lot of things to say.
You can say them. You go for it.
We got to get people vaccinated. Please, please, please. We see, I personally see so much disease related to people that aren't vaccinated, and it just is heartbreaking. And to see that it's and know that it's unnecessary, and it doesn't just affect that person; it affects the rest of their family. It affects where they work. It affects the rest of their community, their other loved ones. I think we have to get away from all about me and my rights and my personal freedoms, and get back to, let's think about the community at large. What is good for our community, our public safety, and do the right things. Maybe not always the popular things with some of the people that you talk to, but the right thing in order to take care of all of us. Masks are not a political tool. Masks are an important part of fighting infection. Are they perfect? No, we never said they were, but they are necessary right now. And hopefully one day we can all go about business and not have to wear a mask that I have to wear every day as mandated by Medicare. But, I want to take the opportunity to thank you guys for having me on. And I'm a big fan of your show. I preach it to all my patients to please watch this because you give such great information. But, I think we'll get through this one way or another. I just hope it doesn't cause us to lose more community members than we have to.
Well, thank you for your great information today. You're welcome back anytime to share your message. Doctor, thank you.
Thank you.
Dr. Hopkinson, final thoughts.
Yeah, I just want to thank our guest today. He's out there with his other colleagues on the front lines in those areas without a lot of resources, doing the right thing, caring for his parents, continuing to get the message out. And there are a lot of them around the state. And, we support you. We're going to be here for you, continue to do the good work and really keep those people, those neighbors, those community members all healthy in your local community. So thank you.
And Dr. Holmes, I was just looking down at our feed, and Bernie said, thank you, Dr. Holmes, for your dedication to your patients. God bless you. So I just want you to know people loving on you and thinking about you and behind you all the way. So just wanted to share that with you. And I just want to thank all of our guests for being with us today. And tomorrow, we're going to continue our talk about COVID, but we're bringing in a former Chief player. He turned from a Chiefs team into a physician, and we're going to celebrate the return of football. So football is officially in the air. Also, Dr. J.P. Darsh is going to join us in studio to talk about playing with the Chiefs, returning as a team doctor, and his close connection to physician and offensive lineman Laurent Duvernay-Tardif. That is my French for the day. So we will see you tomorrow at 8 o'clock. Thanks for being with us. Make it a great Thursday.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.